Okay, so we've covered a lot of high-yield stuff today. We talked about pharmacokinetics, pharmacodynamics, autonomic pharmacology, drug suffixes. Additional high-yield topics include neurology, neurosciences, very high yield for step one, for both USMLE and COMLEX. It's one of those things that students have a hard time learning, so again, the test makers like to test you over this stuff. So neurosciences and neuroanatomy is very difficult to cover in one day. So what we do during the course is we spread it out throughout the entire course. We segment it a little bit here, piecemeal it, a day-by-day basis, so that when we do finally get to the neurology day, there's not as much to cover on that day, and it's not quite as cumbersome for you. So every day we're going to cover a little bit of neurology. So today's neurology is nerves of the upper limb, nerves of the upper extremity. So let's start this conversation on page 368 of First Aid, page 368, in this section titled Upper Extremity Innervation. And this is huge for your test. You need to know these nerves of the upper extremity, types of lesions that would cause damage to these nerves, and then what effects you would have from damaging these nerves. This is at least a 4-star topic, probably a 5-star topic. It wouldn't be surprising to me at all if you had anywhere from 2 to 5 questions on your test over upper extremity nerve innervation. Okay, so on page 368, at the very top you see this diagram, and this diagram with a small text next to it is clarifying where these nerves are and what types of lesions lead to, what type of trauma leads to damage to these nerves. So it starts at the very top with the upper trunk. Upper trunk is lesion by trauma. So you can imagine that, how would you lesion that area? Well, if you have a hyperextension of your neck, such that this angle on your neck is increased, that's going to stretch that upper trunk and possibly damage that upper trunk. So in what scenario do you most commonly have that? Well, you can have that in a motor vehicle accident, specifically like a motorcycle accident where they land on the pavement right there. But much more commonly, you have this during birth trauma. So birth trauma you can have that hyperextension of the neck. And so this is something referred to as Erb-Duchenne palsy. So let's talk about Erb-Duchenne palsy on page 371 real quick. Erb-Duchenne palsy is also called waiter's tip syndrome because it's like that picture illustrates. It's an image of a waiter asking for something, for a tip behind his back. So what is it? Traction or tear of the upper trunk of the brachial plexus. We just saw that image. Follows blow to the shoulder or trauma during delivery. So what happens with Erb-Duchenne palsy? The limb hangs by its side because you have paralysis of your abductors. The arm is medially rotated because of process of lateral rotators, and the forearm is pronated because of loss of biceps. So that's what happens with waiter's tips. You need to be able to recognize that and know that that's an upper trunk lesion. Okay, pretty high yield. Going back to page 368, let's look at some of these other lesions. I mentioned a C7 root. A C7 root is compressed by a cervical disc lesion. So herniation of a cervical disc can compress that and cause problems. What else? This moves on to the other nerves of the brachial plexus. So the axillary nerve is the first one we're going to start with on the upper left of this diagram. It says lesion by fracture of the surgical neck of the humerus. So definitely know that surgical neck fracture, axillary nerve injury. Dislocation of the humerus is another scenario where you can have axillary nerve injury. And intramuscular injections, you can accidentally injure the axillary nerve. So what does the axillary nerve innervate? It innervates your deltoids, which are the primary abductors of your arms. So you're going to have a hard time with abduction, and additionally, you're going to have decreased sensation over your deltoid. So that's one of the ways you test for axillary nerve injury, is you test for sensation over the deltoid. If you have a patient coming in with a shoulder dislocation, test for sensation over the deltoid to make sure the axillary nerve has not been injured. And then after that shoulder has been reduced back into place, check again to make sure you have not injured the axillary nerve. Other lesions here. Underneath the axillary nerve on this diagram, they have the radial nerve in the spiral groove, and this is lesion by a mid-shaft fracture of the humerus. Again, definitely know that. Mid-shaft fracture of the humerus, radial nerve injury. Going on the other side on the right, lower trunk of the brachial plexus, compressed by cervical rib or by a Pancoast tumor of the lung. So a Pancoast tumor is a tumor in the apices of the lung that's compressing this lower trunk of the brachial plexus. And this leads to Klumpke's palsy. So let's talk about Klumpke's palsy on page 371. So Klumpke's palsy and thoracic outlet syndrome, like it says there, it's an embryologic or childbirth defect affecting the inferior trunk of the brachial plexus. A cervical rib can compress the subclavian artery and inferior trunk, resulting in thoracic outlet syndrome. One other thing to be aware of is that hypertrophy of the anterior scalene muscle, can also lead to thoracic outlet syndrome. So be aware of that. Cervical rib or anterior scalene hypertrophy can both lead to thoracic outlet syndrome. So what is it? And it lists these 4 things here. Number 1, it's atrophy of the thenar and hypothenar eminences. So the nerve to the thenar eminence is different than the nerves to the hypothenar eminence. But way up high, we're talking about the lower branch, those nerves come off of the lower branch. Atrophy of the interosseous muscles, sensory defects of the medial side of the forearm and hand, and disappearance of the radial pulse upon moving the head toward the opposite side. Now look further down on the page where it says distortions of the hand, and it lists Klumpke's total claw. So here in first aid, they describe several different types of claw hands. And the Klumpke's total claw is drawn out on the right-hand side of this page here at the bottom right. But what is it as it's described in first aid? It's a lesion of the lower trunk. It's Klumpke's palsy here of the brachial plexus. And because of that, you have loss of function of all the lumbricals. Forearm finger flexors are lost as well, and finger extensors as well are unopposed. So you have clawing of all digits here. So that's what you have with this inferior lower trunk injury. All right, going back to page 368. Other types of injuries. Underneath where we saw Klumpke's palsy on this page, it says radial nerve compressed in the axilla by incorrect use of a crutch. So incorrectly using a crutch can compress the radial nerve there in the axilla. Alternatively, if you are drunk and you pass out over a bench, that can also compress the radial nerve in that axillary region, and that's referred to Saturday night palsy. So Saturday night palsy comes from that description where you're drunk on a Saturday night, pass out over a bench, and then you injure your radial nerve. All right, moving further down on this diagram, the median nerve compressed by the supracondylar fracture of the humerus. Definitely know that. Supracondylar fracture of the humerus, median nerve injury. On the left, radial nerve, the deep branch, is stretched by subluxation of the radius. Let's see what else. The ulnar nerve on the right, lesion by repeated minor trauma and fracture of the medial epicondyle of the humerus. So fracturing the medial epicondyle, definitely know that, is going to lead to a ulnar nerve injury. Moving further down, the median nerve, it says compressed in the carpal tunnel syndrome. So if you look further down the page where it has innervation of the hand on the bottom left of page 368, you see right at the wrist level, you see that flexor retinaculum, and what's going underneath that flexor retinaculum is the median nerve in the carpal tunnel. And like it says there, you have 9 tendons in the carpal tunnel. It's not shown, so it's easy for that median nerve to get compressed and cause carpal tunnel syndrome. We'll talk about what that is in a minute. Going back up to diagram A on page 368, recurrent branch of the median nerve can be lesioned by superficial laceration there. And then the ulnar nerve, like it says there, can be lesioned by trauma to the heel of the hand or fracture of the hook of the hamate. So definitely know that fracture of the hook of the hamate can lead to a ulnar nerve injury at that level. All right, so definitely know those unique scenarios, and if you're presented with one of those unique scenarios, supracondylar fracture of the humerus, fracture of the medial epicondyle of the humerus, fracture of the hook of the hamate, know which nerves you're going to be injuring there. Very high yield to know that stuff. All right, so we're going to skip the brachial plexus right now, and we're going to come back to that on a different day. But on page 370, it lists the upper extremity nerves and sort of recaps the different causes of injuries associated with the nerve damage there and the motor and sensory defects. We're actually going to not look at this page, we're going to look at page 12 of your handout. So looking at page 12 of your handout, nerves of the upper limb. The first one, we're going to cover each nerve in turn, the radial nerve. So what does the radial nerve innervate, and what is seen if this nerve is damaged? So you don't need to get bogged down in every single muscle that the radial nerve innervates, but you do need to know what happens when it's damaged. So with the radial nerve innervates the triceps. The radial nerve is the main extensor of the arm. All right. So if you're injuring the radial nerve way up high, you're not going to be able to extend your forearm. And if you injure it down low, or up high or down low, you're not going to be able to extend your wrist. You're going to have wrist drop. So definitely know that wrist drop occurs as a result of a radial nerve injury. A couple bullets there. The radial nerve innervates the best, brachioradialis, extensors of the wrist and fingers, supinator, and triceps. And then we also mentioned the Saturday night palsy, the radial nerve compression against the spiral groove of the humerus. And with that, you have weak wrist and finger extension, weak brachioradialis reflex, but normal triceps function because of where the radial nerve innervates the tricep muscles. All right, so that's it for the radial nerve. Know those two things. Wrist drop, Saturday night palsy are the two main things and what that looks like. The next one, the ulnar nerve. What does it innervate and what happens if it's damaged? Ulnar nerve damage causes claw hand. And also with ulnar nerve damage, you're not able to adduct the thumb and not able to abduct or adduct the fingers because you lose your interosseous muscles. So what is claw hand? It's described here in your handout. Claw hand is an inability to flex your distal interphalangeal joint of your fourth and fifth digits. It's also atrophy of the interosseous muscles and an inability to extend the interphalangeal joints when trying to straighten the fingers. All right, so this is ulnar claw hand. All right. Now, I know this is very confusing to you guys because different books have different things, and specifically what's in first aid is a bit all over the place and at odds with probably the anatomy textbook that you used in medical school. So we're going to clarify some of these points here. And some of this is a bit ambiguous even to me and to anybody researching this. And honestly, I'm at the point now where I think that there may be some regional differences as to what claw hand is to different regions. You know, it may be the case that in the Northeast claw hand is one thing, and in the West Coast claw hand is the other thing. I don't know because I can't explain the differences and how much differentiation there is in the literature out there. But ulnar claw hand is as described here in your handout. So we're going to start with the handout, and then we'll go back to the book and clarify what's in the book. So moving on, your median nerve. Your median nerve, what does it innervate? It innervates your pronator, so you can't pronate. All right, so what's supination and pronation? Supination is carrying a cup of soup. So when you supinate, you turn up. All right, you have to, in order to carry a cup of soup, you have to supinate. So pronating is just the opposite. So you're not able to pronate if you injure your median nerve. Median nerve damage leads to one of two bigger categories of problems. Bishop's hand or hand of benediction. Sometimes this is referred to as Pope's blessing. So Pope's blessing, Bishop's hand, hand of benediction. Most people, when they say one of those three things, are referring to a median nerve injury. So what does that look like? It's that first bullet under median nerve. It's the loss of the PIP flexion in digits 1 through 3 and loss of DIP flexion in digits 2 through 3. When the patient attempts to make a fist, digits 2 and 3 remain partially extended. That is the hand of benediction, and so we'll see this illustrated in just a second in your book. Let's talk about ape hand. So your median nerve innervates your thenar muscles, the muscles to your thumb. So if you interrupt innervation to your median nerve, then you cannot oppose your thumb. So that's called ape hand. Like it says there, thumb movements are limited to flexion extension in the plane of the palm. So all you can do with your thumb is this. All right, you cannot touch your fingers to your thumbs. This is one of the ways you test for a median nerve injury, is you have the patient oppose their thumb with their other fingers. If they can only do this with their thumb, that's a median nerve injury. We also said that the median nerve goes through the carpal tunnel. So carpal tunnel syndrome, what is it? It's the third bullet here in your handout. Median nerve entrapment at the carpal tunnel, enclosed by the inelastic flexor retinaculum ventrally and the carpal bones dorsally. So there's a high yield question here. An elderly woman with chronic osteoarthritis and diffuse pain now presents with numbness and tingling over the lateral digits of her right hand that sometimes radiates up to the elbow. Exam reveals wasting of the thenar eminence. What is the diagnosis here? So this is classic carpal tunnel syndrome. So don't be tricked by the fact that this numbness and tingling sometimes is radiating up to the elbow. That's very common with carpal tunnel syndrome, to have an upward radiation of numbness and tingling. But wasting of the thenar eminence and inability to hold things, frequently dropping things are all characteristic of carpal tunnel syndrome. All right, and the last nerve on this page is your musculocutaneous nerve. So what is it? Innervates your biceps, your coracobrachialis, your brachialis, so the main flexors of your arm and forearm. Radial nerve is extensors. Musculocutaneous is flexors. Median nerve is your thumb and your pronators. And your ulnar nerve, think of your ulnar nerve as sort of the wimpy nerve of your hand. It innervates your fifth digit, your pinky, with your hypothenar muscles. It also innervates your lumbricals and your interosseous muscles. So your ulnar nerve is sort of the wimpy nerve of this category, of this bunch. Okay, so let's look at page 371. Let's look at page 371 and clarify some of these distortions of the hand that they have here, because I think that, I know this is going to trip you up unless there's some clarification here. All right. Now let me start by saying I disagree with the way that First Aid has labeled some of these things. Let's start by looking at what they call the ulnar claw. So the ulnar claw, they're describing as a distal ulnar nerve lesion. And I would prefer that they didn't say ulnar claw, but rather they just said distal ulnar nerve lesion. Because the ulnar claw, as I described it, is more of a proximal ulnar nerve injury. So there's a distinction between what is a distal ulnar nerve injury and a proximal ulnar nerve injury. So, but the distal ulnar nerve lesion, sometimes this is referred to as ulnar canal syndrome. Ulnar canal syndrome. So it's sort of the homologue to carpal tunnel syndrome, but for the ulnar nerve instead of the median nerve. So this is the ulnar canal syndrome or distal ulnar nerve lesion. They are calling it ulnar claw, but I have never seen it called ulnar claw anywhere else. All right. But what happens here is you have loss of the medial lumbrical function, and more importantly, the fourth and fifth digits are clawed. All right. So what does that mean that they're clawed? It means at your metacarpal phalangeal joint, your knuckles basically, that you have hyperextension of the fourth and fifth digits, so hyperextension, and you have flexion of the interphalangeal joints. So flexion and hyperextension of those. All right. So what they've drawn here in the middle of page 371, at the very bottom in the middle, is a claw hand of the fourth and fifth digits. So that would be the ulnar claw. And again, they do clarify that this is the distal ulnar nerve lesion. They call this Pope's blessing. Now, we just said earlier that Pope's blessing is a median nerve injury, so I would going to disagree with that. I would cross that out. This is not technically Pope's blessing. When somebody says Pope's blessing or hand of benediction, usually they're referring to a median nerve injury, not an ulnar nerve injury. Okay, and the reason why this is confusing to students, if you look at these diagrams, you need to know what is the patient trying to do in these illustrations. So you're looking at this middle illustration of the claw hand, fourth and fifth digits, distal ulnar nerve lesion as it's labeled. Is the patient trying to extend the hand, or is the patient trying to flex the hand? All right, because that makes a difference. Is this a problem of not being able to extend the fourth and fifth digits as they've drawn it, or is this a problem with not being able to flex the second and third digits as they've drawn it? All right, so that's why this is confusing to most students. So if this is illustrating an inability to extend the fourth and fifth digits, then yes, this is claw hand. This is or more accurately, the distal ulnar nerve lesion where you have flexion of the fourth and fifth and you can't extend. All right. So again, if this is an illustration of the patient attempting to extend, then this is the distal ulnar nerve lesion. But what if this is an example of the patient trying to flex, and they are able to flex the hand at the fourth and fifth digits, but they're not able to flex the first and second digits? Then this is a median nerve lesion, and this would be the Pope's blessing or the hand of benediction. All right. So let's talk about this. And this is the Pope's blessing or hand of benediction is as I describe it in your handout. Median nerve lesion. So on attempted flexion, it's an inability to flex the proximal interphalangeal joint of digits 1 through 3. So they can't flex here. So they can flex here. but they can't flex the first three proximal interphalangeal joints, and they can't flex the distal interphalangeal joints of 2 and 3. And that's how we have it described on page 12 of your handout. So again, I know it's a bit confusing, but if the patient on this diagram in the middle is labeled as claw hand distal ulnar nerve lesion, if that is an illustration of the patient trying to extend, then that is a distal ulnar nerve lesion as they've drawn it out. But if in this illustration the patient is trying to flex, then this is an illustration of a median nerve lesion, also referred to as a hand of benediction or Pope's blessing. All right, so hopefully it's more clear to you now. All right, so the next thing they have here on your book, underneath, as far in the text component of the distortions of a hand, it says median claw. So what they describe as median claw is a distal median nerve lesion, and because of that, you have loss of a lateral lumbrical function, and the second and third digits are clawed. So again, what does that mean to be clawed? You have hyperextension of the metacarpal phalangeal joints, and you have flexion of the interphalangeal joints. But this time, this is in the second and third digits. So that's the median claw. All right, so they have this drawn out on the left-hand side at the bottom of the page. Claw hand of the second and third digits, median nerve. Again, number one, I've never heard of the term median claw other than in first aid. All right, so I'm going to disagree with just the term median claw. Median nerve injury, yes. Do they call that? Does anybody else call that claw hand? No. Again, claw hand most people refer to as a ulnar nerve injury. All right, so median claw, as they're describing it, let's just run with it here. On the lower left-hand image, again, is a patient trying to extend or is a patient trying to flex? So if the patient is trying to extend the hand and they're not able to extend the first and second digits as it's drawn out here, then yes, this would be the median nerve injury with flexion of the first and second interphalangeal joints. So the median nerve injury, they're calling it median claw. But what if this is a problem? What if they're illustrating that the patient is unable to flex their fourth and fifth digit? What if this is a drawing of a patient trying to make a fist, but they're not able to flex the fourth and fifth digit? Well, then this is referred to as a proximal ulnar nerve injury. So a proximal ulnar nerve injury can look like this. And with a proximal ulnar nerve injury, you have an inability to flex the DIP joints of the fourth and fifth digits. Inability to flex the DIP joints of the fourth and fifth digits. So with that proximal nerve injury, it would have that appearance. All right, so again, hopefully this is helping you guys, but those are the two main points of clarification with this. All right, moving on, ape hand. What is ape hand? We mentioned this one. This one is a proximal median nerve lesion where you lose your ability to oppose your thumb. And the Klumpke's total claw, we've already mentioned that one. All right. Let's look at page 372 next. So page 372, your radial nerve, you see the wrist drop there. Again, radial nerve innervates the best muscles, brachioradialis, extensors of the wrist and fingers, supinator, triceps. And if you interrupt that, you can't extend, then you have a radial nerve injury. With your hand muscles, let's talk about that for a second. You see your thenar eminence. Your thenar eminence contains your oppens pollicis, your abductor pollicis brevis, your flexor pollicis brevis. So OF is a mnemonic there. Oph pollicis for your thenars, and then Oph minimi for your hypothenars. Your dorsal interosseous muscles abduct the fingers. Your palmar interosseous muscles adduct the fingers. What nerve innervates your interosseous muscles? Tiny little muscles, needs a wimpy little nerve. It's your ulnar nerve, right? Your lumbrical muscles flex the metacarpal phalangeal joints, is what your lumbricals do. Your ulnar lumbricals are innervated by your ulnar nerve, and your radial two lumbricals are innervated by your median nerve. All right, so that is it for describing the upper extremity nerves. So I hope that that's clarified things for you a little bit. Let's go ahead and take a look at page 13 of your handout. Now take a few minutes to answer those questions on page 13 of your handout. There's 6 questions there. And this is a very important question to know the answer to. Number 2 is probably not as important as the other questions on this page. So don't get too bogged down in question number 2. I've thrown that in there just to just to clarify a few things, and because some of those associations are easy to remember. And it is, of course, fair game, although not necessarily high yield. So know the damages of these nerves and what happens when you damage the nerve. So take a few minutes to go through page 13, and then we'll go through these together. All right, so let's go ahead and go through these answers. So first one, claw hand, we said was a ulnar nerve injury. Ape hand is a median nerve injury, inability to oppose the thumb. Wrist drop is radial nerve. A few that we haven't talked about, scapular winging. Scapular winging is a whenever you disrupt innervation to your serratus anterior muscles. So what nerve innervates your serratus anterior muscles is your long thoracic nerve. Your long thoracic nerve, innervation of your serratus anterior. The next one, unable to wipe your bottom. What are we talking about here? We're talking about internal, humerus extension, so extending the humerus, adducting the humerus, so extending it, adducting it, and medially rotating. So extension, adduction, and medial rotation. If you're not able to do that, the muscle that controls that action is your latissimus dorsi, and that muscle is innervated by your thoracodorsal nerve. So if you're going to have a hard time wiping your bottom if you interrupt your thoracodorsal and can't move your latissimus dorsi. Loss of forearm pronation. Your pronators are innervated by your median nerve. Cannot ab or adduct the fingers. These are interosseous muscles. Ulnar nerve. Loss of arm abduction. In general, this is your axillary nerve, which innervates your deltoid. Weak lateral rotation of the arm. Your main lateral rotator is your suprascapular nerve, which innervates your infraspinatus. So suprascapular nerve innervating the infraspinatus. But you do also have some lateral rotation capability with your deltoid, which is innervated by your axillary nerve. So either of those could be a correct answer, but if you have to choose one or the other, go with your suprascapular nerve innervating your infraspinatus here. Loss of arm and forearm flexion. The main flexor of your arm is musculocutaneous nerve. Innervates your biceps, coracobrachialis, and brachialis. Loss of forearm extension is your radial nerve. So this is your innervating your triceps, right? Trouble initiating arm abduction. So the initial abduction of your arm is innervated by your supraspinatus muscle, which is innervated by your suprascapular nerve. So suprascapular nerve innervates your supraspinatus, which does the initial arm abduction, and suprascapular nerve also innervates the infraspinatus, which is a lateral rotator of your arm. Unable to abduct the arm beyond 10 degrees. Again, the initial 10 degrees is your supraspinatus. After that is your deltoid, so it's your axillary nerve. Unable to raise the arm above horizontal. So after you get to horizontal, your deltoid doesn't have to do a whole lot. Other things have to work here, and two muscles in particular. Your serratus anterior has to wing your scapula out, has to rotate your scapula, and that serratus anterior is innervated by your long thoracic nerve. And then also when you go above horizontal, your trapezius muscle comes into play, and that is innervated by your spinal accessory nerve. So two muscles are involved, and two nerves are involved with raising the arm above horizontal. Nerves running with the following arteries. Your dorsal scapular artery runs with the dorsal scapular nerve. The lateral thoracic artery runs with the long thoracic nerve. The posterior circumflex artery runs with the axillary nerve. Your suprascapular artery runs with your suprascapular nerve. Your thoracodorsal artery runs with your thoracodorsal nerve. Your deep brachial artery runs with your radial nerve. Your ulnar artery runs alongside your ulnar nerve. Your brachial artery goes with your median nerve. Your anterior interosseous artery goes with your anterior interosseous nerve. And your posterior interosseous artery goes with your deep branch of the radial nerve. So some of these are more important to know than others, and the other ones that are less important to know they're in here because they're just easy to know, like the anterior interosseous artery and the anterior interosseous nerve. Number 3, What nerve is most at risk of injury with the following types of fractures or injury? Shaft of the humerus is a radial nerve. Surgical neck of the humerus is the axillary nerve. Supracondyle of the humerus is a median nerve. Medial epicondyle is the ulnar nerve. Anterior shoulder dislocation is the axillary nerve. And again, what runs with the axillary nerve? The posterior circumflex artery. So anytime you're at risk of damaging that nerve in that particular area, you're also at risk of damaging that corresponding artery that's going with that nerve. So anterior shoulder dislocation, axillary nerve, and posterior circumflex artery. Injury to the carpal tunnel is your median nerve, right? Number 4, gymnast sustains an anterior shoulder dislocation. What nerve is most likely to have been injured? Axillary nerve, right? An adolescent falls while skateboarding, injures his elbow. He can't feel the medial part of his palm. Which nerve and what injury? This is a broken medial epicondyle. Broken medial epicondyle, which tends to injure your ulnar nerve. So this is an ulnar nerve injury. Last one, high school athlete falls on his arm during practice. In the ER, a radiograph shows a mid-shaft break of the humerus. Which nerve and which artery have the highest risk of being damaged? This is the radial nerve and deep brachial artery. So radial nerve and deep brachial artery. All right, so that's it for the upper extremities. Now also each day we are going to cover some of the rapid review pathology that's at the end of your book. So let's go ahead and turn to that section. I think it adds a little bit of variance to the day and makes things a little bit more interesting. And of course, you wouldn't want to cover all of these in one particular day, so we space these out. Today, we're going to cover 2 of these sections, 2 of these pages. So this is going to start on page 516. And this section of first aid has been drastically changed this year. And there's a lot more information. All the notes that I've been giving students over the past several years to augment this section in previous editions, most of those notes are found in here now. So they've published a lot of those notes, which is good. It's good for you guys. But there are some additional things, and there's some explanation that needs to take place with what's listed here still. So we're going to go through these on page 516. So abdominal pain, ascites, hepatomegaly. Of course, there's other things that can present in that way. But Budd-Chiari syndrome is something to be aware of, is your post-hepatic venous thrombosis. So it's kind of like a DVT, like of your leg, but this is a post-hepatic DVT, so you have congestion of the liver, and that congestion of the liver ends up causing a portal hypertension, and ascites, and abdominal pain, and hepatomegaly. One thing to be aware of with Budd-Chiari is that clinically it looks a lot like congestive heart failure, right-sided heart failure. You'll have lower extremity edema. Hepatomegaly, it can occur with congestive heart failure. But one distinguishing characteristic between the congestion of Budd-Chiari and the congestion of congestive heart failure is that Budd-Chiari will not have the JVD, will not have the jugular venous distension, whereas CHF, congestive heart failure, will. Achilles tendon xanthoma is what you would find on Achilles tendon, in some cases of familial hypercholesterolemia, where so you have huge elevations of LDL, cholesterol levels, and sometimes that cholesterol gets deposited in tissues, and that can be seen sometimes in the Achilles tendon of these patients. Adrenal hemorrhage, hypotension, and DIC. Specifically, the adrenal hemorrhage component is characteristic of Waterhouse-Friderichsen syndrome. It's actually probably more accurate in these clinical presentations and diagnosis disease to start on the right-hand side and then say the thing on the right presents as the thing on the left, because a lot of times the thing that they're writing, the clinical presentation that they're writing on the left can be a clinical presentation of several different things. So, but Waterhouse-Friderichsen syndrome, what it is, it's a Neisseria meningitidis sepsis. So it's not a Neisseria meningitidis meningitis. This is Neisseria meningitidis in the blood, and that causes adrenal hemorrhage, and that adrenal hemorrhage causes adrenal crisis, which causes hypotension, and then additionally, because you have a bunch of bacteria in the blood, you get DIC. So that's Waterhouse-Friderichsen syndrome. Arachnodactyly, lens dislocation, aortic dissection, and hyperflexible joints. So all of these things can be seen with Marfan syndrome. Take a look at your image pages. Image page 1-25, I guess I-25. So image page I-25, image number 99. There's an image there of arachnodactyly. Just, what's the prefix arachno indicate is, spider-like. So these are spider-like digits, spider-like fingers, so long, an elongated hand. This hand always to me looks a little bit like Mr. Burns on The Simpsons, image 99 there. Anyway, so that's morphines. Moving on our list. Back pain, more importantly, fever, night sweats, and weight loss. So anytime you see fever, night sweats, and weight loss, you're going to think about TB, right? If you see back pain, in addition to those things, you're going to think about vertebral TB. And vertebral tuberculosis is given a name, and that name is Pott's disease. Big toe extension and fanning upon plantar scrape. So you take your finger, you take your reflex hammer or your keys, and you run them up the plantar surface of somebody's foot. And if they extend their toes, specifically the big toe, that's Babinski's sign, which means they have they're hyperreflexive. That reflex arc from their toe or from the foot back to their toe is hyperreflexive. So this is an upper motor neuron lesion. Upper motor neuron lesions cause a spastic paralysis, and all that spastic paralysis means is you're hyperreflexive. Why is that the case? You lose that movement inhibition from the CNS. Normally the CNS is suppressing your reflexes at your spinal cord level, so if you do not have that suppression from the CNS, you're going to have that hyperreflexiveness. Bilateral hilar adenopathy. Anytime you see bilateral hilar lymphadenopathy, this is at the hilum of the lung. On either side of the carina of the lung, you have a bunch of lymph nodes there. When you have lymphadenopathy of those lymph nodes, that's indicative of sarcoidosis. Sometimes this is referred to as like hot potato lung, because if you look at this image, you'll see this bilateral hilar lymphadenopathy. Now they also have in here uveitis. Now uveitis is more specific, more non-specific. There's lots of diseases that present with uveitis, but the bilateral hilar lymphadenopathy is more specific to sarcoidosis. It also mentions the non-caseating granulomas. What causes caseating granulomas? Is tuberculosis. What causes non-caseating granulomas? Lots of things. One of those things is sarcoid, and we'll talk about that in the immunology section. Blue sclera is seen with osteogenesis imperfecta. Osteogenesis imperfecta is a collagen defect. Specifically, it's usually a type 1 collagen defect. So there's different types of collagen. Type 1 collagen defect. Take a look at image page 22 at image 90A. Image page 22, 90A, and you'll see there the blue sclera of osteogenesis imperfecta, and you can also see the bony malformation just to the right of that you get with osteogenesis imperfecta on image 90B. All right, moving on. Bluish line at the gingiva. So a darkened line, whether it's bluish or brown, or just a darkened line where your gingiva is at your teeth gum junction. If you see that, that's called Burton's line, and that's indicative of lead poisoning. So the next one says bone pain, bone enlargement in arthritis seen with Paget's disease of the bone. I'm going to give you 3 higher yield ones to know. Bone pain, increased hat size, and fractures. If you see those 3 things, bone pain, increased hat size, and fractures, that's going to be Paget's disease. What is Paget's disease? You have excess bony turnover. You have excess osteoblastic activity and excess osteoclastic activity. What is the primary lab marker for screening for Paget's disease? Is alkaline phosphatase. So anytime you have excess bony turnover, your alk phos level is going to go way up. Moving on, cafe au lait spots is what you see on this image. So just these darkened spots on the skin. Lish nodules is what you see on this image. It's a pigmented iris hamartoma. What is a hamartoma? A hamartoma is excess tissue that's normal tissue for the site where it is. So this is, iris tissue, just a lot more of it. It's a pigmented iris hamartoma. These things can be seen with neurofibromatosis type 1. It also mentions in your book here that you can have the bilateral acoustic neuromas are what you see with neurofibromatosis type 2. So we'll talk a lot about neurofibromatosis throughout the course. One other thing I want to mention here is we tend to do this one-to-one association where you have cafe au lait spots, neurofibromatosis. There are other things that cause cafe au lait spots. One of those things is McCune-Albright's syndrome. McCune-Albright syndrome. And we're not going to go into that. If you want to find it on page 376, you can look at it, but we're not going to go into it right now. Moving on, calf pseudohypertrophy. It's called pseudohypertrophy because it's not muscle hypertrophy. It's actually excess fatty and connective tissue. So it looks like hypertrophy, but it's not true muscle hypertrophy. It's pseudohypertrophy. You have more fat and connective tissue. This is seen in the calves of patients with muscular dystrophy, most commonly Duchenne's. What's the other variety that's less severe of muscular dystrophy? Becker's, all right? But Duchenne's is more likely to have this calf pseudohypertrophy. Cherry red spot on the macula. There's 3 diseases I want you to know here for cherry red spot on the macula: Tay-Sachs, Niemann-Pick, and central retinal artery occlusion. Tay-Sachs, Niemann-Pick, central retinal artery occlusion. Anytime somebody says cherry red spot on the macula, those should be the first 3 things that you think of: Tay-Sachs, Niemann-Pick, central retinal artery occlusion. All right, moving on. Chest pain, pericardial effusion and friction rub, persistent fever following an MI. This is characteristic of Dressler syndrome, which we actually mentioned this one briefly on our review quiz at the beginning of the day. It's autoimmune, occurs weeks after an MI, and it's a fibrinous pericarditis, thus the friction rub and the pericardial effusion. Moving on. Child uses arms to stand up from a squat. This is Gower's sign. So patients on the floor, they don't have the proximal muscle strength. They don't have the muscle girdle strength in their hips to be able to stand up, to be able to squat. So they have to take their arms and walk it back to their feet, then walk it up their knees, and then stand up. If you've never seen an image of that, just go to YouTube, type in Gower's sign, a ton of videos will pop up. So Gower's sign, this is seen with Duchenne's muscular dystrophy. Moving on, child with fever develops red rash on the face that spreads to the body. So this is the slapped cheeks rash. Slapped cheeks rash. And you see that in this image. So this little girl has slapped cheeks. And this is what you see with parvo B19. Parvo B19 causes erythema infectiosum, and the old school term for that is fifth disease. Nobody calls it fifth disease anymore, but just so you are aware of that. The next one, chorea, dementia, caudate degeneration. This is Huntington's disease. My mnemonic for Huntington's disease is there's just a bunch of C's for Huntington's disease. So chorea starts with a C. Crazy starts with a C for the dementia component. Caudate degeneration starts with a C. It's a CAG repeat disorder. It's a trinucleotide repeat disorder. So with each successive generation, those trinucleotides get longer. The number of those nucleotides get longer and longer. Which means it's going to show anticipation, which means it's going to show up earlier or more severely in successive generations. And the other C is acetylcholine. So acetylcholine is decreased in Huntington's disease. What other disease has decreased acetylcholine? Alzheimer's disease. What disease has increased acetylcholine? Parkinson's disease. All right. Chronic exercise intolerance with myalgia, fatigue, and painful cramps. This is characteristic of McArdle's disease. It's a muscle phosphorylase deficiency. They have exercise intolerance. Cold intolerance is hypothyroidism. You guys know that. Conjugate lateral gaze palsy, horizontal diplopia. This is internuclear ophthalmoplegia. So let's talk about that for a second. We're going to discuss this, of course, again another day. But internuclear ophthalmoplegia, how does it present? So the problem with internuclear ophthalmoplegia is lateral gaze. If you try to look laterally, you have paralysis of your adducting eye. So the eye that's going to go to the midline is not going to do that. So this eye is going to look this way, and this eye is going to go this way if I'm trying to look to my right. All right, so paralysis of the eye that's going midline, paralysis of the adducting eye. You have nystagmus of the abducting eye. So if I'm trying to look to my right, this is what's going to happen. If I try to look to my left, this is what's going to happen. Right? If this is happening in both eyes, trying to look to the left, trying to look to the right, that is seen with multiple sclerosis. Now, one thing here is that even though you cannot go to the midline on lateral gaze, you can go to the midline with convergence. So you take your finger, bring it to the patient's nose, and the patient can converge to the midline. They just can't do that on lateral gaze. So very unique presentation and characteristic of internuclear ophthalmoplegia. So two scenarios you can have internuclear ophthalmoplegia. They mentioned damage to the medial longitudinal fasciculus. If it's bilateral, so you see that nystagmus in both eyes, on both lateral gazes, that's multiple sclerosis. And if you see it unilaterally, so it's just happening on one side, and if the patient is elderly, then it's much more likely that this is a stroke that has caused the internuclear ophthalmoplegia. Moving on, continuous machine-like murmur. Everybody knows this. It's a PDA. Closed with endomethacin. Open with misoprostol. What is misoprostol? It's a prostaglandin, right? It has prost in the name. Cutaneous dermal edema due to connective tissue deposition as mixed edema seen with hypothyroidism. Moving on, dark purple skin, and also you can have these mouth nodules. So the dark purple skin you see in this image, this is Kaposi sarcoma. So of course Kaposi sarcoma is associated with human herpes virus 8, which is very closely associated with HIV and AIDS patients. Moving on, deep labored breathing and hyperventilation. Specifically, this is slow, deep labored breathing. And the purpose of this slow, deep labored breathing is to blow off CO2. Because when you blow off CO2, you are going to raise your pH. And you do this in the scenario of diabetic ketoacidosis. So somebody that has a very severe acidosis is trying to blow off a lot of CO2. And so they have this Kussmaul breathing. Dermatitis, dementia, diarrhea. These are the 3 Ds of vitamin B3 deficiency, pellagra. We'll talk about that another day. All right, let's go and do one more page here on page 517. Let's go through these guys as well. So dilated cardiomyopathy, edema, and polyneuropathy. This is wet beriberi of thiamine deficiency, thiamine being vitamin B1. Just FYI, the polyneuropathy in isolation associated with B1 deficiency is referred to as dry beriberi. But if you add dry beriberi with the cardiomyopathy, that's wet beriberi. The next one, dog or cat bite resulting in infection, is Pasteurella multocida. Pasteurella multocida. Make sure you know that organism. Dry eyes, dry mouth, arthritis is the triad that's very characteristic of Sjogren's syndrome. We have autoimmune destruction of your exocrine glands, specifically your salivary glands, which is why you have your dry mouth, and your lacrimal glands, which is why you have the dry eyes. The triad of dysphagia with esophageal webs, glossitis, smoothing of the tongue, and iron deficiency anemia is characteristic of Plummer-Vinson syndrome. So that's a triad that you definitely want to know as well. And Plummer-Vinson syndrome increases your risk of esophageal squamous cell cancer. Elastic skin, hypermobility of joints. This is seen with Ehlers-Danlos syndrome. And generally, Ehlers-Danlos syndrome is a type 3 collagen defect. We had said earlier that osteogenesis imperfecta is a type 1 collagen defect. And so here we see Ehlers-Danlos, elastic skin, hypermobility of joints is a type 3 collagen defect. Enlarged, hard left supraclavicular node is the Virchow's node from an abdominal cancer. Now, classically, it's a stomach cancer that then metastasizes to this Virchow's node. If you see Virchow's node, it's a very poor prognosis in most cases. So stomach cancer can do this, poor prognosis. But other visceral malignancies can present with the Virchow's node also if it metastasizes up there. Enlarged, or moving on, erythroderma, just reddening of the skin. Lymphadenopathy, hepatosplenomegaly, and atypical T cells is Sézary syndrome, which is a cutaneous T cell lymphoma, or mycosis fungoides. These two syndromes, these two diseases are not high yield for step 1. Fair game, yes. High yield, no. Muscle facial spasm upon tapping. So you tap the cheek, CH for cheek, and CH for Chostek sign. Chostek sign, spasm upon tapping the cheek, seen with hypocalcemia. We'll also see what's called Trousseau sign, which is you tighten the blood pressure cuff and you get carpal spasm. That's also indicative of hypocalcemia. Fat, female, 40, and fertile are the F's of cholelithiasis. This is actually a typo here. Acute cholecystitis, those F's are for cholelithiasis, for gallstones in the gallbladder. Now, those gallstones in the gallbladder make you more likely to get acute cholecystitis, but the 4 F's classically are for cholelithiasis, gallstones in the gallbladder. You can refer to page 329 if you want to verify that. Fever, chills, headache, myalgia following antibiotic treatment for syphilis. This is a Herxheimer reaction where you have rapid lysis of the spirochetes, treponema pallidum as a spirochete that causes syphilis, and this results in toxin release, which causes these problems. All right, moving on. Fever, and then your 3 C's. Your 3 C's of measles are cough, conjunctivitis, and coryza. What is coryza? It's like allergy symptoms like runny nose and watery eyes. And also a diffuse rash is measles. Fever, night sweats, weight loss. These are your B symptoms of lymphoma. But what else can cause fever, night sweats, weight loss? We mentioned this earlier. Tuberculosis, right? So include that one in there as well. Fibrous plaques in soft tissues of the penis. This is Peyronie's disease. It's a connective tissue disorder. Usually it's on the dorsum of the penis. Gout, mental retardation, self-mutilating behavior in a boy is seen with Lesch-Nyhan syndrome. The enzyme that's deficient here is HGPRT. This is one of the enzymes of your purine salvage pathway. So we'll talk about that in biochemistry. Green, yellow rings around the peripheral cornea. These are your Kaiser-Fleischer rings. Of Wilson's disease. So Wilson's disease is a disease of copper accumulation. When copper becomes oxidized, what color does it turn? Green, right? So this is why you have these green, this green in your iris. So look at image page 13, image number 51 here. Image page 13, image 51, and you see the Kaiser-Fleischer ring there. That greenness around the periphery of the iris. All right, moving on. Hamartomatous GI polyps. So again, we see this term hamartoma, normal tissue. It's just an excess amount, but it's a normal tissue for the area where it's arising from. You also have hyperpigmentation of the mouth, feet, and hands. This is Pünktz-Jaeger syndrome. Here's an image of this hyperpigmentation. So you can see that. It's very characteristic of Pünktz-Jaeger's. So what is it? Like it says there, genetic benign polyposis that can cause bowel obstruction and does slightly increase your cancer risk. Now, it doesn't increase the cancer risk as much as some of the other polyposis syndromes, but it does slightly increase your colon cancer risk. Moving on, hepatosplenomegaly, osteoporosis, neurologic symptoms is Gaucher's disease. Gaucher's disease, it's a glucose cerebrosidase deficiency. One definitely high yield and characteristic thing of Gaucher's is the crinkled tissue paper cytoplasm that you see with Gaucher's disease. Hereditary nephritis, sensory neural hearing loss, and cataracts is Alport syndrome. So the way I remember Alport syndrome is, you guys know the mnemonic for Reiter syndrome? Reiter syndrome, can't see, can't pee, can't climb a tree. Well, I take that a step further with Alport's, and the mnemonic I use for Alport's is can't see, can't pee, can't hear for Alport syndrome. Moving on, hypercoagulability, just a diffuse hypercoagulability that leads to a migrating thrombophlebitis. And that migrating thrombophlebitis can cause DVTs, but you might have thrombophlebitis in your arms, which is not a DVT, in more superficial veins, which is not a DVT. So migrating thrombophlebitis is classic for Trousseau's sign. And you get Trousseau's sign, this migrating thrombophlebitis, comes and goes, different areas of the body, classically associated with adenocarcinoma of the pancreas or adenocarcinoma of the lung. Hyperphagia, hypersexuality, hyperorality, and hyperdocility are the characteristic features of Kluver-Bucy syndrome, which is caused by a bilateral amygdala lesion. Hypertension, hypokalemia, and metabolic acidosis. Definitely know this. This is seen with hyperaldosteronism. If you know this, these four things for hyperaldosteronism, then you can know what happens when you have low aldosterone levels. So in cases of adrenal insufficiency where aldosterone levels are low, if you have adrenal insufficiency due to adrenal hemorrhage, what caused that? That's the Waterhouse-Friderichsen syndrome, right? But anyway, that's sidetracking. Low aldosterone is going to cause the reverse of this. You're going to have hypotension with low aldosterone. You're going to have hyperkalemia. You're going to have metabolic alkalosis with low aldosterone. So what drugs cause low aldosterone? Aldosterone antagonists, spironolactone and eplerenone. So if you know these four things associated with aldosterone, you can know the presentation of Conn syndrome, you can know the presentation of hypoaldosteronism and adrenal crisis, and also what happens if you have too much spironolactone or eplerenone on board, your aldosterone antagonist. So this little piece of information can broaden your knowledge quite a bit. Hypoxemia, polycythemia, a lot of red blood cells, and hypercapnia is seen with blue bloaters of chronic bronchitis, where you have hyperplasia of your mucus cells. So when you have hyperplasia of your mucus layer in your bronchioles, that's referred to as an increased Reid index, R-E-I-D. Reid index is increased with chronic bronchitis. You get lots of mucus. Moving on, indurated ulcerated genital lesion that's non-painful is the chancre of primary syphilis. This is seen on image page 3, image number 12A. So you might take a look at that real quick. And the last one, infant with failure to thrive, hepatosplenomegaly and neurodegeneration is what you see with Niemann-Pick disease. What else do you see with Niemann-Pick disease? Cherry red spots on the macula, right? All right, so that's it for the rapid review for today. So we're going to do a little bit of these every day. I think this is the only day we're going to do 2 of them. Most every day we'll do just 1 of them. All right, so that's pretty much it for today. So go ahead and take a look at page 14 of your handout and complete the in-session quiz, and then we'll go through those answers together, and then we'll call it a day. All right, let's go ahead and go through these answers. Number 1, what are the 5 classes of drugs used to treat glaucoma? There's your alpha agonists, your beta blockers, your cholinomimetics, your diuretics. There's only 2 classes of diuretics, your carbonic anhydrase inhibitor, like acetazolamide, and then mannitol can be used for acute angle closure glaucoma treatment. And the last category is prostaglandin F2 alpha, like lantoprost. Number 2, how does the blood pressure response to phenylephrine administration change if an alpha blocker is administered beforehand? So phenylephrine is a alpha-1 agonist, has no beta effect. So phenylephrine, after an alpha blocker is administered, is not going to change. You're not going to have any effect on blood pressure. Why is this different than the change seen when epinephrine is used rather than phenylephrine? Phenylephrine or epinephrine does also have the beta-2 vasodilatory effect. So if you block the alpha-1 vasoconstriction by administering an alpha blocker, all you're left with the administration of epinephrine is a beta-2 vasodilation. So that will actually decrease the blood pressure. Number 3, what are the common side effects of beta blockers? Definitely need to know these: impotence, asthma exacerbations, especially with the non-selectives, bradycardia, AV block, congestive heart failure exacerbation, sedation, sleep alterations. And what patient population should you use caution when taking beta blockers? And these are not contraindicated. These patients, beta blockers are not contraindicated in these patients, but they just need to use caution when taking them. Asthmatics, diabetics, anybody, of course, with low blood pressure or low heart rate already, anybody with a heart block, first-degree heart block, second-degree heart block, anybody that's on a calcium channel blocker like verapamil. If you combine a beta blocker to that, you're more likely to get heart block. And, of course, we mentioned also cocaine users or patients with pheochromocytoma. Number 4, what are the various clinical uses for the following sympathomimetics? Dopamine is used for shock treatment. Clonidine is used for hypertension, especially in renal disease patients. Amphetamines have lots of different uses, can be used for weight loss and obesity, primarily used for ADHD treatment, can be used for the daytime sleepiness in narcolepsy patients, and can be used in major depressive disorder also while you're waiting for the antidepressant to kick in. Terbutaline is used for asthma patients. It also can be given for tocolysis to abolish uterine contractions. And epinephrine is primarily used for shock, specifically anaphylactic shock, or if you have extremely low blood pressure that's not responsive to a different vasoconstrictor. The drug categories on number 5, losartan, of course, is an angiotensin II receptor blocker. Vecuronium, curonium tells you that this is a paralytic drug. It's a non-depolarizing neuromuscular blocking drug. What's the only depolarizing neuromuscular blocking drug? It's succinylcholine. All right, so curonium tells you it's a non-depolarizing neuromuscular junction blocker. Tigracillin, tells you it's a penicillin. Dicipramine is a TCA antidepressant. Enalapril is an ACE inhibitor. Lorazepam is a benzo, and rosiglitazone are your glitazone category of drugs that increase the target cell response to insulin. What pathology is associated with the following keywords? Bilateral hilar lymphadenopathy is what you see with sarcoidosis. You have non-caseating granulomas. The hot potato lymphadenopathy, or the potato lymphadenopathy that you see on either side of the carotid of the lungs, what we're talking about here. Cherry red spot on the macula, we said there's 3 disorders you need to be aware of that can cause that: Tay-Sachs, Niemann-Pick, and central retinal artery occlusion. Slapped cheeks rash on a child is seen with parvo B19 virus, parvovirus B19, which causes the erythema infectiosum. Organism associated with dog or cat bite is Pasteurella multocida. Facial spasm upon tapping the cheek is a Chostek sign, CH for Chostek and CH for cheek. Cough, conjunctivitis, coryza, these are the 3 C's of measles. Nephritis, hearing loss, and cataracts. The mnemonic I gave you here is can't see, can't pee, can't hear for Alport syndrome. The next number, what nerve damage? What nerve is damaged when a patient presents with the following symptoms? So claw hand is a ulnar nerve lesion. Wrist drop is radial nerve. Scapular winging is the long thoracic nerve. Unable to wipe your bottom is your thoracodorsal because you're interrupting your latissimus dorsi muscle here. Thoracodorsal nerve. Loss of form pronation is your median nerve. Weak lateral rotation of the arm is your suprascapular nerve. Loss of arm and forearm flexion is your musculocutaneous, the main flexor of your arm and forearm. Loss of forearm extension is your radial nerve, and unable to raise your arm above horizontal is 2 different nerves. Your long thoracic nerve, which is required for your scapula to rotate out, and your spinal accessory nerve, which is required for your trapezius to contract to raise your arm above horizontal. So either of those, damage to either of those nerves can cause an inability to raise your arm above horizontal. All right, so that's it for today, guys. Take a look at page 15 of your handout. I'm not going to do this for you every day because I think you only need this hand-holding for a couple days, and then it's pretty much the case that after day 1 you have it figured out. So, which is why we just do this for day 1. So basically, this is your homework for today. So some of today's information you want to make sure that you know are the 4 pharmacokinetic equations. Go back, especially over everything that I said, definitely know this, or this is a 4-star topic or 5-star topic. That's stuff that you really need to make sure you know. Drugs of the autonomic nervous system. You definitely need to know that. And one way that you can begin learning those is to categorize them based on what you see at the bottom of the page. And this is going to be on tomorrow's review quiz, so make sure that you can categorize these drugs. Very important to know which drugs fall into which category for your exam. Again, it's a 5-star topic. Memorize the G protein second messengers, very high yield. Memorize the nerves of the upper limb. Memorize the rapid review that we went through today. Other things I'd like you guys to do, going through that information is going to take you a couple of hours. I want you to meet with a study partner if you can for at least an hour a day during this last month of your study. Take 25 to 50 questions on your QBank, whether it's Kaplan or USMLE World. You want to continue to incorporate that in your study. Very important. And what I recommend for at least these 25 or 50 questions is you do it on you don't do it on tutorial mode, and you take it in timed mode, all right? Because you need to get practice in pacing yourself. So take it in timed mode, and then after you complete those 25 or 50 questions in a non-tutorial but timed mode, then you can do topic-specific questions in tutorial mode if you want to. But I want you to at least do these in timed, untutorial mode. Review the answers to the quiz. So if you do 25, if you take a 50-question quiz, which would be ideal, that's going to take you an hour, and it's going to take you an hour and a half, 2 hours to review those answers. And then spend 30 minutes to an hour previewing tomorrow's information if you want. Now, you don't have to do that. I mean, really just 30 minutes is probably sufficient. I don't want you guys wasting a whole lot of time previewing stuff because you don't know what's high yield yet. There's some information that you just don't need to worry about, so I don't want you to get bogged down in that type of information. So just briefly review it so that it's fresh on your mind for tomorrow, but don't spend a whole lot of time memorizing stuff that we're going to be covering tomorrow. So that's it for today, and I'll see you guys tomorrow.